Hi everybody, we're Group 3 and today we will be talking about South Africa's Child Support Grant.
When democracy came to South Africa in 1994, children were suffering from racial disadvantage because of legacy of apartheid. 1/4 of children were stunted and nearly 1/5 were underweight, which was a sign of enduring deprivation despite South Africa's relative wealth. Although the government had significant funds to finance the National Welfare Program, the existing state system was inadequate and enforced a strict racial divide. Children's health status reflect their meager diet and unsanitary living conditions in the areas where Black South Africans were forced to live in. In the early 90s, lower respiratory infection and diarrhea, both diseases of puberty, accounted over the 1/3 of the under 5 deaths. Substance abuse, smoking, suicide attempt, unsafe driving, unsafe sex, and violence behavior were common among these adolescents. Early pregnancy was also a big major concern. 40% of the pregnancy in 1995 were among teenage girls. Children and adolescents living in the informal township were exposed to hostile problems impacting their quality of life. One study found that for every young man living with HIV/AIDS in South Africa, up to 8 young women were living with the infection. This marinated threat promoted some researchers to declare the state of emergency for South Africa adolescents.
When Nelson Mandela took power in 1994, he wanted to rebuild the nation. The first thing he did was to address the poverty, but the top priority was to reform the child welfare system because of the growing burden of AIDS was causing the most disadvantages in the community. Kickstarting the reform, the Minister of Welfare and leaders gathered experts through the Lung Committee on Child and Family Support. In 1997, they proposed a new program, which was the Child Support Grant. The program would provide 70 ZAR each month to the poorest 30% of children that were under 7 years old. To get the grant, there was a few conditions. Whoever was going to get the grant had to participate in development programs and had to have proof of immunization. The program was launched in 1998 and had a slow start, with only 22,000 children in the first year. Because of its slow start, it reached the highest level of the South African government. In 2000, the South African cabinet brought together a committee to reform the social security system. They were able to see several problems with the program's conditions and realized some people could not meet the conditions. So this led to the government tweaking the program to expand the enrollment. The program was now determined by age, household income, residency status, which meant they had to be a citizen, permanent resident, or refugee. Before, only children under 7 could apply, but it increased, which was one of the reasons the program expanded so much. The government adjusted the grant size to 100 ZAR to 280 ZAR per month as of 2012. The South African Social Security Agency has overseen the program and offered assistance to help families when applying. They also implemented measures to reduce fraud. The program has continued to help caregivers of eligible children. It remained constant over the years and became more inclusive. By 2012, more than 11 million children were enrolled.
There are two main impacts of the Child Support Grant. The first is that it is good for children's health and welfare. So far, it has led to improved nutrition, more schooling, and less labor force participation. The recipients of the grant are more likely to possess formal identity documents such as a driver's license or identification card. The CSG has also improved the quality and quantity of food in recipient households and reduced the risk of common illnesses such as the flu and stomach ache. With the given money, caregivers are able to pay for health services, transport, medicine, and early childhood development services. Some recipients even use the grant as a form of informal health insurance by borrowing future payments for large unanticipated expenses like a health crisis. The second main impact is that the CSG reduced adolescent-specific risks. Researchers like the DSD, SASSA, and UNICEF reported less alcohol and drug use in children who received the grant early in life. Evidence showed that the earlier the children receive the grant, the more benefits they get because they have more time. The CSG also had effects on other adolescents in the recipient household, even if they weren't the ones who received the grant. These adolescents were more likely to abstain from sex than their non-beneficiary peers. Gender-specific impacts were that the grant reduced sexual behavior that put girls at risk of HIV and adolescent pregnancy, and it also reduced their probability of alcohol and drug use. Then, for boys, it reduced their probability of criminal activity. If you look at the graph to the right, you'll see that there are high probabilities of girls and boys abstaining from these risky behaviors. You'll also see that the graphs are comparisons between individuals who received the grant at the age of 16 versus those who received it at birth. The Child Support Grant was funded through taxation by the South African government. In 2011, the total public expenditure on social assistance was about 3.5% of the gross domestic product. This is an increase of 1.5% since 1994. Then, from 2010 to 2011, the government's expenditure on the CSG was nearly ZAR 31 billion, which equates to $4.2 billion US. Over the years, the CSG has increased its coverage, but its share of national income has remained relatively constant. This is a result of South Africa's economic growth and expanding tax base.
During the beginning stages of the Child Support Grant, Trevor Emanuel, who is the finance minister, had worries that the system was going to be unsustainable, but many steps were taken to ensure its success. The first one being the government's commitment to providing the sufficient social grants in order to reach equality. This was a big achievement because South African society had been struggling through structural inequality due to apartheid for so many years. Enrollment was also made easier for the beneficiaries. The documentation that they were required to provide in the enrollment process was made more accessible and feasible. And we've learned throughout the semester that documentation such as birth certificates are important in analyzing demographic trends of a society and also their health status. And an example was that parents were able to receive their birth certificates at the hospital rather than having to go somewhere else to pick them up. But the facilitation of documents that they needed to show that they were still eligible was still a challenge. And in 2008, about 1 in 4 caregivers were not able to provide these documents, so they couldn't apply for the program. The communication between the government and its residents is also another reason for success of the program. The South African Social Security Agency has taken precautions to not only reduce the risk of fraud, but also increase efficiency of the program. And with new technology such as the internet and a telephone voice-activated system, critical information is able to be spread faster, and wait times are also minimized at pay points. Vocal rural authority figures are also used to spread information in a higher volume. Lastly, the pressure on the government to remain accountable is another contribution to the success of the program. The DSD and SASSA analyze evidence and they work to identify any problems within the program. All the information is available online. The platform that residents use to share their experiences is called GroundUp. So if there was any major complaint within the program, the government would most likely be aware.
The implications for the South Africa Child Support Grant is that it is a powerful weapon against HIV. Due to increased income, it reduced the motivation for sexual risk behaviors. Children who benefited from this program overcame the constraints of their parents' disadvantages and continue to go to school. It also increased the numbers of government social workers that furthered and amplified the benefits of the transfer. To continue, the implications for this program is that it empowers female caregivers rather than male heads of households. Children who had mothers that were also enrolled in school benefited more from the transfer than children whose mothers had minimal schooling. Overall, this program improved health directly by helping to pay for services, transport, and medicine, and indirectly by reducing poverty and influencing the social determinants of health.
Our case study and presentation has a strong relation to the class's most recent lecture in regards to the importance of women's health overall, the importance of children's health overall, and the idea that most women and children's disadvantages occur in lower income countries, just like South Africa. As for the importance of women's health overall, as discussed in the most recent lecture, being born female is hazardous to your health. Women are victims of discriminations in both high and lower income countries, and the issue of women's health is not an isolated issue. Like our professor said in the lecture, healthy women make healthy children, and healthy children turn into healthy adults, and those healthy adults create a good economy. That being said, it's not only a human right, but it's vital that all women have the opportunity to and live healthy lives. In regard to the importance of children's health overall, we discussed in the lecture that 5.4 million children under the age of 5 die of preventable death each year, and many of those deaths are linked to poverty. And not enough is being done in certain parts of the world in reducing childhood morbidity and mortality. And it's just important to remember that children are literally the future, and more needs to be done to ensure that they're able to live out long, healthy lives and create that future for us. And as for most women and children's disadvantages occur in lower income countries, just like South Africa, we discussed that as for children, 99% of childhood deaths are in low and middle income countries, and half of those deaths occur in India, Nigeria, the Democratic Republic of the Congo, Pakistan, and China. And these are all just countries so similar to South Africa, as we discussed in our PowerPoint. And as for the women, one of the top social detriments of women's health is low social status, which is the norm in these previously mentioned countries. So this status limits access to healthcare, limits education, and overall just limits the power over women's lives and their bodies, which definitely needs to change, as we discussed.